My name is Tisha Dean, and I will be presenting today with Chris Rule. And we're just going to introduce ourselves and get started. Welcome. We're glad you're all here. Like I said, my name is Tisha Dean. I'm a clinical psychologist. I was born, raised, and educated in Arkansas, so you don't have to wonder about the accent. I did my PhD in psychology at the University of Arkansas in Fayetteville, did my internship at UAMS, and a fellowship in health services research at the Central Arkansas VA. I'm involved in training psychology interns and postdoctoral fellows in integrated behavioral health, and I direct, along with my esteemed colleagues, Kathy Emmons and Ruth Fissel, in the behavioral health integration program in the primary care and population health service line here at UAMS. My expertise in integrated behavioral health stems from my background as a rural Arkansan and my love for the principles of behavior change and psychology. My career is really focused on integrating behavioral health to increase access to behavioral health in primary care, because I know that it really is a way to provide services to people who really need it. So that's me, and I'm going to let Chris introduce himself.
Good afternoon, everybody. I'm Chris Rule, and I am, as it says here, the Director of Behavioral Health at Baptist Health UAMS Family Medicine Residency Program, also an instructor in the departments of Family Medicine and Psychiatry within the College of Medicine. I've been doing this work now for a while, since kind of at UAMS, been training and teaching residents in the Department of Family Medicine since about 2007, 2008. I'm really passionate about resident education and training in behavioral health. Really worked hard in the last several years to put together an integrated behavioral health clinical service along with Baptist Health in our new residency program over here. Been doing that for the last 3-4 years. I've been involved with mental health and behavioral health for, I don't want to say how long, a long time, and have worked in schools, have worked in pediatric settings, in adolescent settings, in private practice, and in various roles at UAMS for a long time. And this is something I feel really strongly about, which is really integrating behavioral health to, as Tisha said, improve access to behavioral health services for all that come into primary care. And as I said a minute ago, just love the aspect of teaching family medicine residents and producing the next generation of family medicine physicians to go out there and really feel very well versed in taking care of all their patients' behavioral health needs.
Thanks, Chris. So today we are going to talk about behavioral health integration, the past, the present, and the future. Our objectives, as you've already read, are that we're going to talk about the history of behavioral health integration into primary care, and also talk about how that specifically has played out in our areas and at UAMS and at Baptist, and talk about the evolution of this integration and team-based care, both kind of from a more theoretical perspective and then from our more personal and perspectives in our respective organizations. And then we also then want to go into and talk about the future and what are some of the future directions, both again for the integrated care in general, and then also in our specific areas that we work. So we wanted to start today by setting the scene. This talk could have gone a lot of different ways, and there's so many things to talk about. I'm going to lay out some assumptions we're making in order to talk about our specific topic today. And each of these assumptions could be a talk in themselves, and mini talks, classes. And so please find me or Chris, and we would be happy to bore you for hours about these topics. The first assumption that we're making is that We agree, and we know that the patients that are in our primary care clinics, um, that we see, have many undiagnosed and or untreated mental health illnesses. Many people that we see have issues related to behavior and mood and mental health that is not recognized or is not treated adequately. We also know that there are people who present with stress-related symptoms, or that they have specific medical conditions that are exacerbated or things get worse because of stress. We also know that there are many barriers to accessing traditional or specialty mental health, such as cost, stigma, availability, and personal readiness, and perceived need for care, and that these barriers are exacerbated for our marginalized and minority populations. So these are some of the things that we recognize about the patients that we see. Another one that that I wanted to acknowledge and recognize is that our family physicians and medical professionals, you have many skills to identify, treat, and manage these above problems yourselves. And that you are able to recognize and help manage patients with both chronic medical illnesses and mental health problems. And at the same time, it's really hard giving the demands placed on your time and the constraints of healthcare. And the last assumption that we're making today is that we assume that most people in our audience know from looking at the research and believe that integrated behavioral health is effective in helping address or alleviate some of these problems. So again, like we said, if you want to talk about some of these assumptions, we'd love to have that conversation with you. So I also want to set the scene a little bit by just talking about what we consider integrated primary care. And based on some of the research and writings about this. So we say that integrated primary care combines medical and behavioral health services. And my addition is to that also behavioral and medical principles and models together to address the problems patients bring to primary care. This includes stress-linked physical symptoms, maladaptive health behaviors, and or mental health and substance misuse concerns or disorders. So basically, the idea is for any problem, patients have come to the right place when they come here to primary care. There's not a wrong door to get the care that they need. So now we're going to talk a little bit about some history, put things in context. And Chris is going to give us some great information.
Thanks, Tisha. So a brief history of the world as it relates to behavioral health integration in primary care, and how it really kind of had its beginnings in family medicine. As I like to refer to, there's very few truly new ideas out there. And this idea of some kind of integration between behavioral health and physical health has been around for a long time. At the beginnings of the UAMS family medicine residency and the program as a department, it was really there at the beginnings of it, or shortly after anyway. And they had, as part of residency education, commitment as the precepts and tenets of family medicine were being implemented at UAMS. There were behavioral health folks working in the clinic to instruct residents about these important issues. It wasn't until probably 30, 40 years later, we'll see a timeline in just a second, that clinical care services were introduced at UAMS. And this really became more visible and part of the mix when there were a variety of sort of quality service and payment reform initiatives rolled out on a national level, and UAMS was a leader in participating in patient-centered medical homes, CPC Plus, and now again, kind of primary care first. And these programs did a lot of things, but what they also did was sort of help to use consensus guidelines and evidence-based care approaches to support and incentivize behavioral health integration across primary care settings. Really like this little timeline. I know it's really busy, but it's very effective to see this across the very beginning years of family medicine, and family medicine education is sort of where behavioral health and how that grew over time. This divides sort of these eras into sort of early, middle, and current. And we see, I highlighted a few of these things, but we see that, you know, the STFM, the Society for Teachers of Family Medicine, was really founded in '67. I think it's important to note that it was almost 20 years later that it was, there was first a task force that outlined certain core competencies for behavioral science. So in that early period, there was a long time, and there were certain milestones along the way that helped encourage folks to reach some competency consensus. During the middle period, there was, as we'll see in just a second, a lot of research and publication around different models and principles that we're going to talk about today. But it was really building off of those core competencies in behavioral science that were things everybody was agreeing to. More recently, we see that the Society for Teachers of Family Medicine groups of combining kind of family systems and behavioral science groups. That's currently the largest STFM interest group from the mid-2000s. And then a very important kind of piece of work by CJ Peak and a panel of experts around the country involved with the National Center for Quality Assurance really began to outline a behavioral health, behavioral science lexicon for integrated care. And this came out in 2013. This really helped us to kind of agree upon not just the same vocabulary words that we're all trying to use, but also a way forward in terms of models of care. As part of that, and just pulling a few pieces back from this timeline, what we see is that there were behavioral health services that were kind of unevenly migrating in and out of primary care settings over the late 80s and 90s. There were certain programs in certain areas of the country that were really advancing on this rather rapidly and putting these models that we talk about today together and then doing research on it. And that's where a bulk of the work on collaborative care actually, and sort of the things that were much of what we talk about today in terms of integrated care kind of was born out of that period. Primary health integration was really started in earnest here, or restarted, as we might say, at UAMS as part of the new service line kind of structural change across the campus. And when those service lines were created, I believe it was around 2015, first at UAMS main campus and then regional programs, we were rolling out behavioral health clinical services at that time. Baptist Health was beginning its own initiatives around that time about integrating behavioral health into primary care clinics as, again, part of using dollars and monies from sort of CPC Plus, but as well as sort of incentivizing how behavioral health can be located in these clinics and work together. Around that time, again, there were different models that were being utilized in both places. There was primarily a behavioral health consultant model, or BHC model, that was really being used. We'll talk about this more in a minute at Baptist. And then there was sort of a combination approach that was being utilized at UAMS at the time. And when I first started there, in this particular model within primary care, we had social workers, we had some psychologists, we had a psychiatrist for a brief period of time. So we were trying to throw a lot of things at the wall and see what was going to stick and what could be implemented effectively. This quick and interesting kind of slide is sort of just quickly highlights what interestingly kind of what was getting published. What if you look at the PubMed searches, and this study did a quick look at kind of these slices of time in early, middle, and recent years, you see definitely a consensus in terms of what terms were being published in behavioral science. Clearly today, I think the interest in you see this period is coalescing around collaboration, certainly depression, anxiety, and mental health services. And we hope that we'll see growth in this current era in more publications around collaboration, increased publications in integrated care.
Thanks, Chris. So now I'm going to talk a little bit here about kind of the where we are now. So some frameworks and models that have shaped and continue to shape the vocabulary, understanding, and practice of integrated care right now. So first, I'm going to talk about a framework here, and then I'll talk a little about some specific models that are used to kind of deliver care within these frameworks. So the Substance Abuse and Mental Health Services Administration, or SAMHSA, and the Health Resources and Services Administration, HRSA, published this framework for understanding the levels of integration of behavioral health services into what are considered medical settings. So these are also sometimes seen as steps, as many organizations begin at one level and aspire to more integration over time. The key takeaways from this slide is the ideas of coordination, co-location, and integration. There are differences in how these types of programs impact clinic life, the patient experience, and provider experience. So coordination is very much focused on communication, so increasing communication between these two different types of services. Co-location increases the communication and the physical proximity, and integration really increases the communication, the proximity, but then also merges and transforms practice. Another key takeaway is that as far as research goes, there's really not evidence, and there's no necessarily better level than another. There's no randomized controls trials saying that one way of doing things is better than the other that I'm aware of, but that fit and meeting the needs of the patient in the clinic are the important things to success. So no matter where we are on these levels, it's how we are actually meeting the needs that's important. So now I'm going to do a little fun visualization that helps us to understand this integration a little bit better. So level 1 and level 2 are coordinated. So on this level, we have this cookie, or kind of our medical services. And then we have our chocolate chips, which are our mental health services. And because I'm a mental health professional, I'm going to be the yummy chocolate chips. So in level 1, the level 1 and level 2 are kind of coordination, right? So in level 1, the cookie has to go across town to get the chocolate chips. In level 2, there's some coordination. So there's a bridge between the two and kind of some direct communication. In level 3, we're kind of getting to this co-location where the chocolate chips are in the same place as the cookie, but they're still very distinct entities. They're still doing their own things. You can think about having an already baked cookie and then putting some cold chocolate chips on the top. Our next levels of integration are some different types of cookies. So in level 4, we're still co-located, but there's less distinction between the cookie and the chocolate chips. You have to dig a little bit to separate the two. And then when we get to level 5, now we're getting into the integrated types of care where they're mixing together nicely. There's places where you can't really distinguish what's a cookie and what's a chocolate chip. So this could be that the physician or nurse or MA helps the patient learn breathing techniques to decrease their blood pressure and anxiety. Or the mental health professional or behavioral health consultant is teaching patients about A1Cs and how that's important to how their health and well-being, how they can think about their health. So this last level is the fully integrated cookie/brownie bar. It's really turned into something else entirely. It's not a chocolate chip cookie, but a very integrated team of yummy ingredients that meets the goals together. So when we think about this integrated model, like how integrated are we? We have different types of ways to deliver these integrated types of services. So I want to talk just a minute about talking about the difference between models and programs. This is something that's come up kind of in our profession recently, and has kind of helped me to dispel some confusion. So I think models are theoretical, repeatable types of kind of programs or types of services that I can take this model of how we do things, this workflow, these different pieces of how we communicate, these specific types of tasks, and I can take them from one site and put it in another site. A program is more of how we implement these models or how we do things in a specific institution or clinic. So it's a specific way of doing what we want to do. So programs can be based on models, but they may be completely different and basic and not related to any model of care. So some of the models that have kind of come out of different areas of family medicine, psychiatry, psychology, social work, there's two kind of big models that are floating around right now. One is called the primary care behavioral health model, or as Chris alluded to, it can also be called the BHC model, because most of the behavioral health providers who work in these models are, they call themselves BHCs or behavioral health consultants, which is what we use. And I'll talk a little bit more specifically about that model in a minute. The collaborative care model is more of it came out of psychiatry and primary care, and it is a little bit different way of kind of pulling services together and helping to integrate behavioral health and psychiatry into primary care. And then there are blended or continuum models, and these are models that tend to take pieces of these models and try to pull them together. And we'll talk a little bit about why that might be important or why that's something people might want to do. So this is just kind of a more of an illustration. As we stated, the models we're going to talk about are all considered within kind of this umbrella of integrated, or it's sometimes called interdisciplinary or transdisciplinary care. So we've got different disciplines working together to provide care in these different kinds of integrated care settings. So we've got the primary care behavioral health, PCBH model, we've got the collaborative care model, COCM, and then we've got these blended models that take both pieces together. So just briefly, the PCBH model is something that I consider kind of a horizontal type of care delivery. So it involves the part that the behavioral health consultant or the mental health professional is part of the clinical operations. They're physically or very, very virtually. So if they're virtual, they are very integrated and easy to get and are able to see patients and see and talk with providers very easily. They're physically available for nearly all issues, from prevention to serious crisis and needs. So they are there as consultants to the primary care providers, the nurses, the MAs, all the people in the clinic, and they are there to help manage and deal with and work with the population that is in the primary care clinic. It's based on, or one of the ways to understand it's called the Gather model. So basically the primary care or the behavioral health consultant, it has generalist care. So they have lots of knowledge about different types of things to do. So help with sleep, help with diet, help with chronic pain, help with changing in behaviors, help with anxiety, help with depression, be able to recognize and manage mental health crises, all those kinds of things. They're very accessible, so they're there, available, have time whenever the needs arise. Team-based, so really integrated with the teams, high productivity, so matching the model of primary care and seeing patients quickly and when they are needed, provide education both to patients and to the clinic, and also part of the regular routine. So that's the PCBH model. The collaborative care model, as I think of as more of a horizontal model that cares for a specific group of patients. It involves the systematic and regular review of cases with action and feedback. So this model allows for a psychiatrist, you see the little picture on the side, the psychiatric consultant works with the behavioral health care manager, which can be a different person or it could be a BHC, that in the patient, that they work together to manage the patient. So the psychiatric consultant and the behavioral health care manager works with the medical provider to manage the patient. You see the psychiatric consultant doesn't necessarily see the patient. They may once or twice, very briefly, but they are assisting the medical provider and the BHC in managing the patient, so they can provide consultation on medications, consultations on diagnoses, and they regularly work with these patients with a registry, which is a list of patients, and they manage these patients with the registry with the behavioral health care manager. So these are usually a specific group of patients, like patients with depression that's not getting better, patients who have both depression and diabetes, things like that. These are recognized by specific CMS billing codes. And lastly, we have our blended or continuum models, and so our programs. There's not really a model for this yet. This is kind of cutting edge on the newer side of things, except the VA has been doing it for a very long time. So you've got the whole clinic patient population, and you think about like the PCBH model with the BHC provides a lot of services for many of the patients and helps to manage that entire population. And they see regularly a group of those patients over the period of time, and a wide range of severity and types of issues, and not just mental health issues, but management of chronic medical conditions and sleep and other things like that. The COCM is provides for a specific type of patient, and they provide targeted interventions. They manage patients for a specific period of time, help them to get stabilized, help everybody to understand what's going on. And then when the patients are doing better, then the patients are continue to be in the patient population of the primary care, but they're not followed by the collaborative care team specifically at that time. So when you have both, then you have kind of this wide range of services, but then you also have this specific group of patients that you can kind of go in and out of this other program.
So these models and kind of implementing, we're going to shift to that and talk about some of the challenges in maintaining integrated care. It's been instructive to work kind of some in each of these and have a foot sometimes across the continuum that Tisha described, because it's important that we see, as one of the key challenges is getting used to doing the work in that space and in that setting, and then documenting how we kind of clinically intervene with patients. And as behavioral health consultants, or as social workers in this space, I can recall early on with our rollout at UAMS, I used to get a lot of questions and field a lot of questions from both attending physicians as well as residents, is just based on preconceived notions about what social workers could do and what they couldn't do, and that was based on my licensure and background. But there was a lot of questions early on about what can you help us with? How can you do this? What interventions are you going to be doing in clinic? And then how will that then be documented in the chart? And we had a lot of challenges in maintaining that approach as people learn the new model. And as it says here, we can kind of have clinics that have clinicians that are embedded in it. But then there can be a pretty significant load that's placed on that BHC to kind of have responsibility for various elements of integrated care. And then the fire hose flood of different things that just can walk into any family medicine clinic is often difficult for a BHC kind of training into this model, coming into this model to implement the various elements of it as they go. It's often the case, because of the way we've created our healthcare systems and our billing systems, that we can, and I think this is a trap, honestly, that we can fall into, and that we begin to kind of chase visits, as it says here. And that we can fall into that sense of like, we're not getting enough of these. And these handoffs, for example, lead to us being able to see clients in a longitudinal way. Or if we're not getting enough of certain things, we can then chase other things down. We need more substance use interventions. We need to expand this. And so we can get in the habit of kind of chasing the rabbit, and that can lead to burning everybody out. Likewise, when we're kind of working alongside and parallel with physicians, it can kind of create some confusion. And there's always an ongoing, and I think hopefully a synergistic kind of approach to educating folks about the awareness and the breadth and the depth of problems that we can treat and take care of right here, right now. And then the ones that we need to be really having our radar up for, like the ones, patients and the problems that need to be referred rather immediately. We talk a lot in our own clinic about, because our access is so good, and we really want to tout the fact that we have this really great access and patients can come in and we can see them rather immediately. We talk a lot about bridging folks over, but we kind of go down two lanes of the road at the same time. And we really work to try and help physicians understand that we have to kind of, if we're going to initiate some services here, that this patient's particular problems or the kettle of fish that we're kind of looking at here needs to be also probably referred simultaneously to a specialty care setting. And that's really an access related issue, because the wait for getting into specialty mental health is often several months. As we're all kind of dealing with in the present, billing complexity and sustainability are kind of present everyday challenges. We are working to maintain that, and we started out as a way of kind of throwing things at the wall and seeing what bills would stick and what things would get paid, and then now we're trying to be a little bit more strategic. There has been Tisha mentioned that there has been certainly some expansion of codes by Center for Medicaid and Medicare Services federally, and then states have adopted more and broader codes that we can begin to bill for certain services and expand those services. But reaching a sustainability level for these teams and funding positions within clinics is kind of an ever-present and ongoing challenge. The last one here is really about workforce, and we have to be very mindful that training a workforce is a very recent dilemma for us to try and have folks who come into working in this space. I have had, a relatively short time, career speaking, in working in primary care and working in family medicine. It's certainly the home I really feel at home here, and it's the home I always needed to have. But training the new folks to come into this is not something that was on anybody's radar 10 years ago. In that same space, I think we have to be very mindful that we are also competing against other models and other directions that the health system and the mental health care system is going. And that speaks to making sure that our positions are structured properly and paid in a competitive way based on the marketplace that's out there. We are also really striving to build a very diverse workforce. We are taking care of diverse populations, and that will only increase over time. And we need to have an equitable balance in terms of who we're seeing and the workforce that's providing those services. Some of this is a bit of review. I'm going to skip to kind of the middle of it, where we talk about, kind of how we restarted the primary care service aspect of this. And it's, when we look at it, I think when we pause a minute and zoom out from kind of where we were, less than 10 years ago, with starting with a couple of social workers and no other clinics in the primary care area really having these services, rolling that out at the time, then Kathy Emmons was really working feverishly to roll stuff out across regional programs. We have really done a tremendous job at getting to where we are today, where we have folks across the state working and applying this model, physicians who are figuring out the way that they use behavioral health consultants and integrate this into their programs. And then also, and we'll talk about this more in a moment, there's just sort of the really intensive work we've done to educate and train providers and build that next generation of residents. And as I like to say to just as applicants who are applying to our residency program, you're going to get a really solid training in behavioral health here. I want residents leaving our program and graduating from residency and then demanding of their future employers, where's my behavioral health person? Because this is the way we all need to work. Importantly, we have to see that there's going to be more diversity of practitioners that are working in this space. It's really critical to see the growth across time, that it was primarily PhD and social work practitioners who were doing this type of work. But now it's including more licensed professional counselors, or LPCs, folks who have the marriage and family therapy certificate, and then also really broadening the interdisciplinary team and sharing the shouldering of the behavioral health load, which is including clinical pharmacists, expanding medical assistance training to include important elements of triage and assistance for patients on multiple levels. They are the folks, and as long as with the care coordinators, who are the folks on the phones, who are talking with these patients day in, day out, who are interfacing with the physicians and between the behavioral health folks and the physicians. And we need more of that as we continue to grow. There's a substantial evidence base for it already, but it's growing in our evidence base and knowledge of how quick assessments can really benefit patients, using evidence-based screening tools, and then allowing us to target specific behavioral health interventions to help with those patients right there, right now. We are certainly increasing our education and training in BHI for our residents and our teams that address these critical elements. We are moving more into helping them understand and actually practice and utilize in real time with real patients in our clinic counseling interventions that include motivational interviewing, cognitive behavioral techniques. I would also include kind of acceptance and many mindfulness techniques, behavioral activation, and then sort of a very popular and widely known model for SBIRT, which is screening, brief intervention, and referral for treatment with substance and alcohol use. Now we're going to shift and kind of really focus more in on future directions.
Thank you, Chris. That was a really, really great overview and really spot on what you were talking about. So now we're talking about kind of future directions. And I'm going to show you a very busy slide, but it's really for me to kind of give you an idea of the vision that we have for the kinds of clinical services and workflows that we hope to see throughout our system in primary care at UAMS. And I think this is probably pretty similar to also what's going to be happening around the country and also in other areas around the state. So basically, if you look at this, the first part is just patients are identified for needing support for mental health, behavior change, anything that's related to, what we've talked about today. And then the core piece of our team, the core piece of behavioral integration is our team. Our behavioral health consultants, we have behavioral health resource coordinators, and hope to expand we have psychiatrists. We hope to expand the kinds of team members that are kind of involved there. They're kind of the hub, the top kind of like arrows going around is a lot of what we already have. So a lot of our clinics already have what we call primary care behavioral health model, or they have an embedded behavioral health consultant and or behavioral health resource manager that identifies, helps assess needs, and then provides targeted intervention. So like Chris was talking about before, motivational interviewing, brief cognitive behavioral therapy, acceptance-based and commitment, SBIRT. We track based on measurements. So we give people PHQ-9s and G87s, these measures that help us to see if people are getting better or worse. If they don't get any better, we refer them to specialty care. And when they get better, then we follow up with them as needed. So they're continue to be part of our clinic and part of our population, but we are not following them. You see the middle arrows, that is when someone, comes to our team, and then we recognize that this is something that's outside of the primary care world, and this person needs specialty mental health care. And then, so they get referred and coordinated directly to that. The bottom kind of arrows is what we would think about as the collaborative care model. You can talk to our great friends in Batesville who've been doing this for a little while with our psychiatrist, Dr. Tripathi. But here, the patient is identified as being in that vertical group, the team, the population that would benefit from psychiatry consultation. They get enrolled in that, and then the psychiatrists and the BHC have weekly consultation meetings about this group of patients, and the psychiatrist would provide recommendations and consultation to the primary care team about what might be helpful. The patients are monitored, measurement-based tracking, and then again, just like the top side, if patients don't get better, we refer them to a more specialty mental health treatment or other kinds of care. And when they get better, they move back into the primary care general population, and we follow up with them as needed. So I hope that's helpful. I know it's a lot, but that's kind of the way that we envision being able to provide these services in the future. So just some future directions and things that we've been working on. This last year, our team had a Blue and You grant that provided really great training for our BHC team and our Behavioral Health Research Coordinators team to provide them some training in some of those brief targeted interventions, and also just about this model to help them to work within their clinics, and also just to support them in their continued education. And most importantly, I think developing this training so that whenever we have new hires, we'll have a really robust training so that we are all start out and end up on the same page. We have a new grant coming through the pipeline that is specifically focused on implementing the collaborative care model and blending the models in this next year. And so we're trying to create a program for UAMS that incorporates both models. And there's also a HRSA grant, part of a HRSA grant that's helping us to kind of develop some medical school training to help our medical students to start to become aware of these kinds of models and different types of things they could be learning to kind of get those juices started early.
So I'm going to speak a little bit to some future directions with training for family medicine residencies, and then sort of training across all of family medicine team members. As we are looking to expand this across different clinical settings and in different ways, we have to see this, and family medicine has recognized this over time, but it's not the same in every particular discipline that necessarily works in a primary care clinic. But family medicine is at the hub of the wheel, focusing on the doctor-patient relationship and a longitudinal continuity relationship with patients. They're really central to understanding that this has to be a core component of family medicine training and practice. And the new guidelines, that I'll show in a minute, really reflect this. We have to continue to work and expand our training upstream. As Tisha just mentioned, we are looking at that and moving things more into training med students, more into training graduate social work students, and more into other graduate schools of psychology and trainees, so that they are getting experiences in these models and in these clinical settings. And the response so far with this work as they come into it is really tremendous. The teams in the medical clinics really appreciate these learners coming in. They really get and click with the sort of multidisciplinary approach. It's really fun to work in, and it's fun to watch when it happens well. We have to also see and I think continue to push forward and advocate for this expanding across all aspects of primary care. This is where the access is. This is where we have to focus and put our workforce. We are not going to grow enough specialty mental health folks or psychiatrists to account for this need that's out there in our populations. So we have to look to kind of put these folks into, and I know Children's has been working on this feverishly in the past few years to really expand mental health services again across their pediatric settings, but we are doing it in internal medicine here at UAMS. We have to continue push to do it in other primary care, especially settings like OB-GYN and other sectors that really are where these patients are and what these needs that are presenting to those clinics. We have a lot of questions we have to still answer. We have unevenness in the research that's out there so far, but we also wonder whether are we impacting and decreasing disparities in access because of these programs. The initial evidence is positive in this regard, but as I said, it's stuff that we still have to ask more questions about and gather more data. We are talking presently about how do we capture our data here, both at UAMS and Baptist, and then we will hopefully present on that in future meetings, certainly to this group, but then also nationally, because what we are doing is certainly part of what is on the national radar for how this is rolling out. We have to also congratulate ourselves just a little bit, but we are ahead of the game. It's really nice to know that the future is now, and we are out there because of what we've done in the last several years to really push these things forward. The leadership across the campus in multiple departments is really making this happen, from psychiatry to family medicine to internal medicine, and within the service line directorship. It's really been terrific to kind of have that support across this time. Now we have the two largest medical institutions at the state working in, separate now, but we have a lot of partnership opportunities that are working towards this to really help support the rollout and increasing both the workforce as well as the collaborative efforts across behavioral health integration. And we only see a positive future in how this is growing. Before we end and shift to questions here in the last few minutes, we do have a little thank you slide. So thanks to everybody who's worked not only on our teams, but kind of worked with us hand in glove to make this so successful.
Thank you, Chris. I love that we're giving ourselves credit for the good work that we've done. And I came in about a year and a half ago, almost 2 years ago. It'll be 2 years in May. And that's one of the things that I was so excited about, was the great work that's already been done. And the foundation had been definitely laid very strongly by you and Kathy and Ruth and all the people who came before us, me. So I'm really appreciative. Also on this thank you slide, we've got our team members. I cannot say enough about our fabulous behavioral health integration team that we have here at UAMS, and I know Chris has a great team also. And also, thank you very much to Dr. Turnage for suggesting that we come to talk today, and to our leadership. Since I've been here, the leadership has been nothing but incredibly supportive. So now we will go to questions. And it looks like we have questions. Do you see the integration of medical and behavioral health payments and services being recognized by insurance anytime in the future? I can start. So there's a few changes that have been happening. One, as we have alluded to today, Medicare does recognize and has specific codes for the collaborative care model. So there's billing for the psychiatrist and the behavioral health care manager to work together. So when their meeting time, you can bill for that time. There's billing for care coordination, sort of like you can bill for care coordination in other medical areas. As far as behavioral health payments, there's different ways. It just depends on how the model is developed. And we are really looking on our team to be able to see if there are ways that we can be more efficient in our billing, our ability to bill for some things that maybe aren't, that were not built to bill for yet. The last thing is Medicaid in Arkansas did just make some changes to make it easier for primary care providers to hire mental health providers. They don't have to go through this weird long process with Medicaid, which is, I think, will be a big barrier. Another thing we are working on, me personally and some people along the state, is to get collaborative care codes recognized by Medicaid in Arkansas. They're not yet. Do you have anything to add to that, Chris?
I would just say that systems have been slow within internal systems, and slow to adapt to some of those changes. And the capture of our billing and revenue is still kind of very segmented. But it's my take on that is because they were siloed for so long, and behavioral health was carved out of primary care, and the billing systems and the capturing of revenue systems were not there. I see it changing, like Tisha mentioned. I'm frustrated all the time about how we can't kind of seem to get that linkage better. But I think it's going to change rapidly. There's going to be a lot of change in the next, I would say, 2 to 5 years.
I would agree with that. There's another question. It says, are there any plans that you are aware of to apply for SAMHSA funding or other funding to increase integrated care across Arkansas?
I don't know of any. I know that there's an organization called the Arkansas Behavioral Health Integration Network that is a nonprofit that works in the interface around training and training providers, as well as and they have some grant supports that's mainly educational in focus, and training primary care providers. They have looked at some of that. I think we have to be creative in how we look for funding. But I also have to, I think funding through, if we're talking about funding for supporting positions, I think we get into, we can wedge ourselves into corners if we're looking to use that to solely fund positions in the future. I think we have to be creative about how we fund and create this workforce. I think if we wedge ourselves into a corner by saying these are always grant funded positions, we run the risk of saying these are not essential elements of primary care clinics that are funded through the stream of primary care dollars that goes to fund the work we do. So I think we have to be very circumspect about things like that as we go.
Yeah, I completely agree, Chris. That's some of the problems with grant funding is grant funding eventually goes away, and the positions do not. And so we want to make things sustainable and to build things within the structure of our clinics rather than relying on grant funding. But I do, like I had talked about earlier, I have a Blue and You grant that is going to bring in expertise from the University of Washington AIM Center, which is kind of the mecca of collaborative care and integrated care. And so some good friends who are there too, and they're going to come and look at our clinics and tell us, you know, some of the barriers and help us to think through this billing stuff and help us to think about our work processes and give us some training. And so there's certainly those kinds of grants I'm incredibly interested in. And if anybody would like to help and do some grant writing and get involved, come and we'll do the work. So we've got one more question, Chris. It says, rural health providers have always struggled with access to behavioral health colleagues. Now Arkansas faces a shortage of family medicine providers. Integration of services seems like a practical solution. How long do you think it will take before we see the impact of this change?
The impact of this change, I think, is something that has to be accelerated. I think we have a growing consensus of agreement that this old way of kind of, you know, factoring and moving people in and out of different systems is still tilted towards a system that we know has been inadequate. And I think we have to kind of put the pedal down and accelerate this to move folks into this. I think we have to look creatively at collaborative partnerships with community mental health. Tisha and I were talking about this the other day, kind of briefly. We have multiple ways we could kind of see this being done, but we have to have both policymakers and leaders and directors across these different sectors in mental health and in primary care, in universities, and in larger health systems, all kind of begin to see that this is where, again, everybody agrees to a lot of the principles here. This is where the access is. This is where we can rapidly kind of work and treat patients. And this is where the bulk of the patients already get their primary care. a great article by Patty Gibson in, I think it was the Arkansas Medical Society Journal or the Family Medicine Journal of Arkansas recently, is reiterates what we've already known for a couple of decades. Primary care is the de facto mental health system out there, and we have to recognize it by continuing to forward to move these types of services into those types of clinics.
So we have one more question, very briefly. We're out of time. The question is, what is I'm guessing the balance at UAMS between pediatric and adult focused BH work? The one thing I can say is that I know in our regional programs and our internal medicine clinic at Rawlins, the ones that see children, that our BHCs are available to see people from anyone who shows up in the primary care setting. We don't have any specific people who are just there to see pediatric patients. And we're certainly, our psychiatrist is not a pediatric psychiatrist, but a lot of times what happens is that the psychiatrists who do work in these settings can get support and get some consultation if there's a pediatric patient that needs help. I hope that answered your question.